Hi, this is Andrea, and I'm here with you for HIT 210, and we are now on Chapter 12. If you look in Brightspace, you'll notice that there's already videos posted for Chapter 12. Um, Last spring, when COVID hit, we went from being in class and face-to-face to being online, and that's when I developed those videos. And the ones for Chapter 12 and Chapter 13, and I think that they are more thorough and more practical than what is in the book. But since you're tested on what is in the book, I need to post um, chapter 12 as it is based in the book. So that's what this lecture is about. If you turn to page 231 in your book, it starts with chapter 12 on diagnostic coding. All diagnostic coding is ICD-10-CM. So that is where we're going to begin. This just goes through the overall objectives according to the book. And between my other video lecture and this one, you should be able to get all of this taken care of. So I'm just going to skim through these. So basically the reasons for and importance of coding diagnoses, importance of matching the correct diagnostic code to the appropriate procedural code. Now, because you are not doing inpatient coding, we are not doing ICD-10 PCS. So you won't need to worry about procedural codes until we get to chapter 13 and we begin with CPT-4. But anyway, you'll want to differentiate between primary or first listed principal and secondary diagnoses and discuss admitting diagnoses. You'll want to look at how medical necessity is supported by the diagnosis code. We'll talk briefly about the history of diagnostic coding. We'll discuss the benefits of the ICD-10 coding system. We'll differentiate between the ICD-10-CM and the ICD-10-PCS systems. Basically, CM is diagnosis, PCS is procedural, but PCS is only used in hospitals for inpatient procedures. So you'll never use ICD-10 PCS, and we aren't going to teach you how to code that. You're just going to focus on ICD-10 CM because that is the diagnosis coding used in both the inpatient and in all other settings. So as we look at the ICD-10 CM coding manual, we'll talk about the alphabetic and tabular indexes. We'll define and demonstrate understanding of diagnostic code conventions, symbols, and terminology, apply coding guidelines, and chapter-specific coding guidelines. We'll look at those, and additional coding guidelines specific to outpatient services. We'll talk about those, and becoming more familiar with codes commonly encountered in a specific healthcare organization and computer-assisted coding. Then we'll briefly touch on future changes to diagnosis coding. ICD-11 is already in use in a couple of places. It'll be a few more years before it reaches us, but it is coming, and that's the next modification we'll see. All right, so diagnosis coding for outpatient professional services. There are guidelines for diagnostic coding that have to be followed when assigning codes. Only diagnoses that currently relate to patient state should be coded, unless there is a history that the physician believes is part of what is going on. So for instance, let's say patient comes in and they have arm pain, and it's in their upper arm and it feels like it's in the bone, not the muscle. And this patient has a past history of lung cancer. That history of past lung cancer may need to be coded because that arm pain may be due to bone metastases. So that's an example of where the patient doesn't currently have lung cancer, but the fact that they had it in the past may be very pertinent to their current situation, and that's when you would code that. Payment for services may be tied into diagnostic coding due to medical necessity requirements. We talked about that a little bit in chapter 11. In order to get paid, you have to justify that with the patient's condition. Diagnostic coding has to be accurate because payment for services rendered to a patient may be based on the diagnosis, and that's not just in the inpatient service realm, that's everywhere, including skilled nursing facilities, including behavioral health facilities, including home health, hospice, any of those. That's why diagnostic coding is so important. In the outpatient setting, the diagnosis code has to correspond to the treatment or services rendered. Otherwise, there may be a chance of denial. There's a certain sequencing of diagnostic codes. You basically put your primary or first listed, this is your chief complaint or main reason for the encounter, that's always first. And secondary diagnoses are anything other than that. You won't need principal diagnosis. That is terminology used in the inpatient side of life. So we aren't going to really get into it, but it's very similar to primary diagnosis. So admitting diagnoses, this is for inpatient side of life. This is why what bought the bed, so to speak. Why is the patient requiring an inpatient level of service? So that's where you get into admitting diagnoses. Medical necessity, insurance companies may not cover procedures that are not diagnosis related. We'll talk a lot about that when we get to chapter 13 and we're doing CPT coding, that our ICD-10 diagnoses need to support what we're doing with CPT. That's what they're saying here. And then we will talk about NCDs and LCDs. Let's see, what week is that? I want to say that's in chapter 13 as well, since that is the biggest place of that. Let me see, hang on. Well, we definitely talk about medical necessity in week 13. But prior to that, I wanted to say we did talk about NCDs and LCDs. But I'm not seeing it at the moment. But we will. Anyway, those are policies about medical necessity. And each insurance also has those, their own version of NCDs and LCDs. The federal government does NCDs and LCDs, but insurance companies have their own. And we'll go out and take a look at some of that. So what is the history behind diagnostic coding? Diagnostic coding has always been done using the International Classification of Diseases. That first official version started in 1948, and it was really to look at causes of death. Causes of death began being recorded in England during the 1600s. But that didn't morph into this big book. If you ever see an actual coding book, it didn't morph into that until around 1948. The US started using ICD in 1950. In 66 was ICD-A8. And then in 1979, they began with ICD-9-CM. And ICD-9-CM lasted until 2015. 14, 15. It says here 14, so I guess I'll go with that. We are now still using ICD-10-CM. And interestingly enough, this is just sort of trivia, but you can see it was actually developed in 1992. It wasn't actually implemented here till 2014. And we were one of the last countries in the world to make that jump. Everyone else made it well before us. But ICD-11 is now starting to be used in a handful of places. And I think that they're looking for us to make that jump in the next 3 to 5 years. All right, so this talks about the transition from ICD-9-CM to ICD-10-CM. You don't need to know about this. It's in the past, it happened, it was major while it occurred. But really, everybody uses ICD-10 these days, and they have been for several years. So knowing about ICD-9 CM versus ICD-10 CM isn't going to be a whole lot of help to you. It says here that non-covered entities are not required to implement ICD-10, but I can't imagine any MA working for a non-covered entity. So we're going to go off the idea, the reality that you'll be using ICD-10 if you're doing diagnosis coding. The process of looking at diagnosis code is the same. You use the alphabetic and then you move from there to the tabular. And you'll see exactly what I'm talking about when you look at the other video for chapter 12 that I did. And it's just, this is just information about ICD-10, that it's much bigger, it's much more expanded, it has greater specificity, it has greater flexibility for the future, and all sorts of other things. There are crosswalks called GEMS that you can use. They're not the best, but they're not the worst either. But again, you won't have anything to do with ICD-9 CM, so you won't need to worry about crosswalks or anything like that. And this just talks about the benefits, again, trying to persuade people that ICD-10 is a good thing, and it is. Don't get me wrong, I've used both, and there are benefits to using ICD-10. It's just my frustration at the moment with these slides from the book company is that you're going to use ICD-10. They don't need to convince you of that it's better than ICD-9, because all you'll really know is ICD-10. So it just seems a bit of a waste to me. So this just gives you the official titles. What you need to know is ICD-10 CM is used for diagnosis coding, and it's used in all settings, no matter what it is. PCS is only inpatient, and that's why we don't cover it. It is updated annually. There's a tabular list and alphabetic index. You always start with the alphabetic index and then move to the tabular. And when you watch the other video, that will make perfect sense. Annual updates are published in several different publications. The federal government's fiscal year always starts on October 1st. And so that is why you'll see everything coming out in September for ICD-10. Occasionally they do mid-year updates, such as this past year with COVID. They did a couple of different updates because they needed to get information and new codes out. So the alphabetic index contains the the tables of drugs and chemicals, the neoplasm table, index to external causes. The main code descriptor items are in alphabetical order. And again, just please go watch the other video because I'll walk you right through it and show you how to do it. You can read through this information, but I don't think it'll make sense until you're actually in and working in ICD-10. But you still need to know it for your test, I suppose. Tabular list, this is where you get to the actual alphanumeric codes. ICD-10 codes have 7 characters with a decimal point always after the 3rd character. The first character is always going to be alpha. The next ones will be numeric, and then after that they can be alpha or numeric. X is used as placeholder. And some things to know, you sometimes need to use 2 or more codes to describe what's going on with a patient. Sometimes 2 or more diagnoses will be included in one code. And you try and get to the most specific code that you can based on the documentation in the chart. And it's important to read all instructional notes. These are just code book conventions, and I actually walk you through all of those in the other video. Coding guidelines, it tells you again, start with the alphabetic index, then go to the tabular list. And again, you want to code to the highest level of specificity based on the documentation in the record. If your provider does not give you the specificity, you can't go there. You're going to have to back the code off to a more generic version. You always have to code to what you have in your documentation. If you think your provider can provide you with additional specificity so you can get to the code that you think it should be, then you can query the doctor, and we can talk about coding queries later. Signs and symptoms, sometimes that's all you've got, and no precise diagnosis can be made. These are transient, and you code those just as they are. If you have a diagnosis, you need to use that. And I think there is, in that video for chapter 12, the other one that I made, I think there is a slide in there about signs and symptoms and test results are not diagnoses. And what you're really looking for is diagnoses. But in the outpatient setting, sometimes you can't get a diagnosis. All you can get are signs and symptoms. And that's what you will code. You don't code conditions that are an integral part of a disease process. So, for instance, if you have a patient with lung cancer, you don't code cough or shortness of breath unless they are unrelated to that condition. So that would be an example. When would you code cough with lung cancer? I can't really think of an example that you would, because cough and shortness of breath are common with lung cancer. So I guess if you had if the patient had an upper respiratory infection and their cancer was stable and they had not been coughing, then you might pick that up for that. And in terms of use additional code and code first, that's in the other video. You code acute conditions first, followed then by the chronic condition. A lot of times there's a combination code that you may use. Late effects, especially with a patient with stroke. Maybe they have difficulty swallowing, and so you want to make sure that even after the stroke is no longer acute, that if they're still struggling to swallow, that you go ahead and code that. Impending or threatened condition, this depends on what the book directs you to do. An example might be an impending heart attack or threatened miscarriage, those types of things. There's ways to code those. You should only use the same diagnosis code once. You can use procedure codes multiple times, but your diagnosis code should only be used once. And if you're talking about laterality, then your code really needs to reflect that. Sometimes you need to document body mass index or BMI or pressure ulcer stages. As long as that is documented in the record, you can code it. It doesn't always need to be a physician. Sometimes it can be a dietitian. Sometimes it can be a nurse. Those types of things. Syndromes, you'll have to look and see what the book says about those as you code those. If there's complications of care, you need to make sure that based on what's documented in the record, that's what you code. And then you get into chapter-specific coding guidelines, and I go through all of these in the other video. So I'm not going to talk about them here. And I cover all of these as well. And you can look at your book. This is on starting on page 251 is where this information is, and you can take a look in here. It talks about rule out and other things. And then these are some hints. And then computer-assisted coding. There are now what are called CAC systems, computer-assisted coding, where the software uses artificial intelligence. It goes through and looks at reports that are already in the system and pulls out phrases or items that it thinks are diagnoses or procedures and puts codes to those. And then you go in and you review the documentation, review the codes. You either accept some, you accept the ones that you agree with, you eliminate the ones you don't. You can do some additional coding on your own, but it's meant to sort of give you a jump on coding, especially if there's something common, easy that the system can pick up that the coder doesn't have to really worry about. So yeah, ICD-11, they began working on that in 2007. It has come out already. Like I said, there are a handful of countries around the world that have implemented it, but it'll be a while for here. All right, that's it for chapter 12. Just really encourage you to go back and take a look at the other videos because I think they'll be more helpful. And when we meet next Monday, which will be the 15th, keep getting my weeks mixed up and I apologize for that. So we will meet, we will have class on Monday, February 15th, barring any more computer glitches. And we'll have our discussions about ICD coding and Coding Clinic resources and guidelines. We'll do additional coding exercises together. And then you'll have your workbook exercises. Notice that you do not have a quiz on chapter 12 for several weeks, and that's to really get you comfortable with ICD-10 coding. There will not be class on February 22nd. It turns out that I'm having to do a virtual conference online, and the speakers for the morning session, the 22nd, 23rd, 24th, are live. So and I'll talk more about this next week when we meet, but just know that we aren't going to have formal class on February 22nd. But we will get together again next Monday, which is February 15th, and I look forward to seeing you then. Take care.